So we have invited a number of people to join us, and we look we're over 100 people that are logged in, and about 400 that would like to get this. So get this on the replay, so it will be recorded, as I mentioned. And I just want to confirm that at least one or two of you can tell me that you are seeing the screen and you are seeing me. The verification of pelvic floor activity with volitional contraction through real-time ultrasound sonography. So I'm looking for somebody out there to answer me and let me know that you are present and that you can see what we're doing.
Can't see.
Cannot see. I see that. And let's see if this helps. We'll ask that same question again. Are you able to see the presentation? Excellent. So we'll go ahead and get started. Thank you for helping me out with that. This is a topic that has been dear to my heart for the last probably 3 years, and I've been doing some work with Hadar Schwartz from Israel, who also is working on her doctorate and looking at pelvic floor activity. And the first question that we had was, do people really do what they think they're doing when we ask them to lift their pelvic floor? So we created a pilot study, and before I start that study, I do want to do a poll, and I just want to see what you guys think out there is the right answer. So I'm going to put up a poll question right now, and you all should be able to see it now. So the poll's open. I want you to take a minute and just read the question of what percentage of people who think they're lifting up their pelvic floor are actually lifting up their pelvic floor. But this was the question we had, and we were pretty surprised by our results. I'm sure you can see the numbers rolling there. We're looking pretty good. 78% voted, 80% voted. Keep it going. This is fun. This is better than trying to catch Pokemons. And we're about there. So thank you for participating. The correct answer is 55%. So give yourself a pat on the back if you were choosing the 55%. So when we look at the study, this was, and I have to make a clarification here that as we look at the background of this research that we did, we know over the past 30 years that the pelvic floor has been shown to be an active player in producing intra-abdominal pressure. And we've seen that back as far as Dr. Punjabi's work, looking at stability. Paul Hodges definitely has added to that library of research. And as a result, we as physical therapists, Pilates teachers, and other restorative movement practitioners have incorporated these active pelvic floor lifting activities to try to increase intra-abdominal pressure, just like we do with the abdominal hollowing or trying to contract the transverse abdominis. And so with this all being sort of the hype, and we had a lot of people trying to teach, and we see lots of courses about pelvic floor, we really wanted to understand this a little bit better. And so what we did is, in the very first study, we now have over 250 Pilates teachers that we have data on. But I'm going to present to you the first study now where we had 79 persons, and then the third study where we had 45 subjects. And this first study, we had 79 experienced Pilates teachers. So these were people that typically had over 5 years as a Pilates teacher from all different schools, all different ages. And we basically had a standard protocol to look and observe with an ultrasound to see if they were able to lift their pelvic floor when they thought they were lifting their pelvic floor. And that's really the question. And all we're really measuring here is your proprioception correct? So if I tell everybody in the audience right now, lift up your left hand, and all of you lifted your left hand up in the air, that would be accurate proprioception. But if I said lift up your left hand, and 45% of you put your left hand down, that would be similar to what we're seeing in the pelvic floor activity. Now, this does not mean that there is necessarily a problem associated with it. It just means that we're finding that 45 to 50% of Pilates teachers who think they're lifting up their pelvic floor are actually pushing it down. So we divided them into three categories. The first category was women who successfully lifted their pelvic floor when they thought they were lifting their pelvic floor. So that's group A, and we call that the true group. And then we had the second group, group B, was the pelvic floor descended when the subject thought that they were lifting their pelvic floor, and we call that false. And the third group was inactive, which was when they did the self-cueing, there was actually no activity. So we didn't see any lifting or pushing down. So let's take a look and see what this looks like. I hope you all can see the ultrasound images on the screen. And if we look here on the left-hand side of your screen, you'll see where my arrow is. That should be what I'm referring to as left. You'll see the dome, and the darkness above that dome is the bladder. So what the dome represents is the pelvic floor, and then the space down below would be either the thighs or the pelvis itself, the pelvic bone, and the pelvic floor in the middle. So here you see the pelvic floor in its resting position, actually pretty high. And then on the next one, the contraction, we see that it lifts up. So if I drew a straight line across, you would see that it's probably about almost a centimeter higher than the resting position. So this would be a positive or a true pelvic floor lift. And the next one we're going to look at was actually the opposite. So here we have a resting position, and we draw that line across, and we see that the pelvic floor is actually lower. And I'll come back to this one a little bit later, because we do see an elevation as if the muscle's contracting, but the abdominal pressure pushing down has pushed the viscera down, 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 and that's why we're seeing the pelvic floor dropping down. So the question here might be, are they actually contracting their pelvic floor, but the intra-abdominal pressure is so high that it actually pushes it down relative to the resting position? And we can take a look at the next one here as well. And this one's a little more clear, a nice full bladder. And we can see the line that I drew and show the difference. And this would be a clear example of not using the pelvic floor. And when they thought they were lifting, they probably were just increasing intra-abdominal pressure and pushing the pelvic floor down. Here's another example of that. Here's resting position. If I drew a line straight across, you would see that the height here is about almost a centimeter, again pushing it down. The pelvic floor thickness in this image is about the same as the pelvic floor thickness here, which would tell me they probably are not activating muscles like the pubococcygeus in this position. And again, if you have questions, please feel free to ask. I have some help monitoring it to make sure that we won't have a problem. All right. All right, just making sure we're good here. All right, let's take a look at another one. And here's an example, again, that by measure, this would be a false because the height of the pelvic floor on the after is lower. But we do see the dome of the pelvic floor coming up. So that was similar to the first one, where again, I think that they are actually getting a pelvic floor contraction, but they're using so much intra-abdominal pressure that they're actually pushing the pelvic floor down. All right. And then the last one I have here, another example of same height of the pelvic floor and relaxing, but when we look across, when they thought they were contracting the pelvic floor, we see a decrease or a drop in the pelvic floor. All right. So the outcome results of this are as follows. Group A, we had 35 of those 79 that actually lifted their pelvic floor up when they thought they were lifting the pelvic floor up. We had Group B, the false group, where 36 were actually pushing the pelvic floor down when they thought they were pulling the pelvic floor up. And as I mentioned, there were some who looked like they were actually contracting the pelvic floor, but the intra-abdominal pressure was too great and was actually pushing the pelvic floor down relative to the resting position. And we had 4 that were inactive. There did not seem to be a difference in whether they were postpartum, if they had had vaginal delivery or C-section, their weight, their age, the years teaching, and even the school that they taught at. So this was a very interesting thing, that 45 to 50% failure to lift the pelvic floor accurately with self-cueing was so prevalent. Like, how is it that we as Pilates teachers and physical therapists were so unaware of what was actually going on in the pelvic floor? So that led us to other questions and other thoughts. And the purpose of this pilot study was just to see if we were using volitional contraction for muscles, if that actually got in the way of what we were teaching them to do, or if it was facilitating the increase in intra-abdominal pressure. And so I'd like to stop here for a second and open the floor up for some questions you might have before we move on to the study. And that is my question to you is, do we need to do volitional contraction of the pelvic floor to teach core stability and increase intra-abdominal pressure versus something spontaneous that we would experience while we're teaching a Pilates class, for example? Anybody have any questions? Oh, that drops. Now I'm seeing some questions. Good. Barely. How can I make that bigger? I see some questions coming in, and I'm going to open this up here. Give me 1 second. That's what we did in that little tiny line. All right. So first question was, what exercises were they doing while lifting the pelvic floor? And all we were asking them to do in the traditional way of measuring the pelvic floor was to imagine lifting their pelvic floor and use the cue that they would use in their own teaching. So we allowed them to use their own cueing system to do that. So there was no exercise at this time. Oh, I can't get that bigger. Sorry guys, just trying to get used to this as well. Here we go. Oh, how'd you do that? Okay. And yes, Teresa asked, was the test position supine? And yes, the test position was in supine. We have since looked at it in other things, which I'll talk about in a minute. But that was the standard way that they look at pelvic floor lifting in all the literature so far. And I think Laura had the same question. And what is the relation between the adductors and the pelvic floor lift? This is from Carol Ann Thomas. This is a very interesting question. Some of you might be familiar with Pilates, P-F-I-L-A-T-E-S. And that is, they look actually at the adductors. Now, we'd expect to see carryover, but again, when you're thinking of what the pelvic floor's purpose is, I would tend to keep the adductors in a separate category than I would the actual pubococcygeus and the pelvic floor sling. But that is a great question, and there's more research coming out on that as to do the glutes and the adductors have a relationship to the pelvic floor. What I would dare say is that we probably over-recruit the adductors and the glutes thinking that we're lifting the pelvic floor versus actually using them to recruit the pelvic floor. Wendy Price asks, would love to add into study of tactile cueing first with the pelvic floor. PT specialist or women's health would be beneficial. We have been working with Pam Downey. Some of you might know Dr. Downey. and she is one of our lead authorities on pelvic floor and women's health. And we know that when we do see, for example, that one case, Carol Ann, that I showed, the pelvic floor was actually lifted and domed, and we still saw the increased pressure pushing it down, that would probably tell us that there was some kind of either contraction or restriction that was there to begin with. And I think what's interesting about that, and Pam talks about this as well, and I've read in the literature, is things like incontinence can be just as frequent with an overactive pelvic floor as with an underactive or flaccid pelvic floor. And so that question there, I think that's what we're looking at is definitely we could use that. We did not in this case because it was me doing the testing on Pilates teacher on the floor at the PMA. But we're definitely looking at some of these cases with Pam as we go into the next study that I'll talk about in a few minutes. Let's see, another question. The inhale creates, this is from Nancy Sanchez, is this true the inhale creates the initial intra-abdominal pressure from the diaphragm, and then the exhale can assist with the lift of the pelvic floor to finish the support, and over and over? Nancy, you're reading my mind. That's where we're going next, so I will be able to answer that question for you as we continue to do that. And those are the questions for now. So let's go back to the slide presentation. Thank you very much for your questions, by the way, and participating. When we look at the conclusion here, I think the safest thing to conclude from this pilot study is that we don't really know that what we're cueing the pelvic floor is actually activating what we think it is. So I would, first of all, be careful of thinking that that's what's happening. And you might need an ultrasound, or if you are a women's health physical therapist, you could palpate and see what's going on. But I think from us just assuming that the image of lifting the pelvic floor up or stopping the flow of urine or pretending that you're holding on to a feminine device, that those, I think that assumption would be incorrect. And I think the other thing that we know from this is that we don't know how that pertains to spontaneous pelvic floor organization yet. And that's where I want to take you, is what we've been working on. This again is Hadar Schwartz out of Israel and myself. We did another pilot study in the last PMA, and what we did is we were looking to measure spontaneous pelvic floor activity. And this is a little bit different. So we wanted to know, we already know volitional, and volitional over and over again. We now have over 250 subjects volitionally that are right around 45% think they're lifting the pelvic floor up and they're actually pushing it down. So what we want to know is, what about this mechanical, which is what Nancy brought up with the breathing, where you would have a natural elasticity. When the inhalation of the diaphragm descends, the intra-abdominal pressure will naturally push the pelvic floor down, and then the exhalation of the pelvic floor will actually naturally spring back up. So you're looking more at elastic properties rather than contractile properties. And then the other variable we wanted to look at was spontaneous organization of the pelvic floor. So we did a little bit of research, and we found out, and this goes back to one of the questions earlier about what position people were in. We do know that supine is not the ideal position to measure pelvic floor contraction. I think we're pretty comfortable with that. And it makes a lot more sense when it is organized in the line of gravity, which is how we are organized in standing, sitting, squatting. And so what we decided to do is, in the literature, it said that sit to stand was one of the greatest organizations for intra-abdominal pressure, and that we would assume that the pelvic floor would have its greatest contraction or organization or lift and an activity like sit to stand. And so what we did is we broke the group down, and we did the same sort of series using the ultrasound. And the first group, we did our volitional contraction. So we had 45 Pilates teachers that were tested. And of those 45 teachers, 20 of them that thought they were lifting the pelvic floor and they're pushing it down. So we saw that same exact pattern that we've seen over and over again. Now, the mechanical one was very interesting. So the idea of breath, where we just asked them inhale and exhale naturally. So a forced inhalation and a forced exhalation. And we were able to observe and see that 41 of the 45 teachers had normal displacement of the pelvic floor, and it correlated with the descension and ascension of the diaphragm. So we were really excited to see that. I have a question from Tom Welsh. So in the first study, did you ask the participants what cue they were using? And if so, was there any correlation between the cues used and the response observed? Tom, that's a great question. Good to see you on the page there, Tom. Tom and I go back about 25, almost 30 years in the dance medicine world. And Tom, great question. We didn't really have time to ask them exactly what they were imaging. We just asked them to use the image that they would use to teach their clients. I think the interesting thing in this was how surprised they were that they were not actually lifting their pelvic floor up. And I think that would be a great future study, is to looking at the idea of proprioception with volition, is to find out exactly what they were thinking or using as their image. Moving on, and again, thanks, Tom. The spontaneous contraction. Now, this was the one that was the most interesting to me, and this is where I've sort of been in my literature, where I've been in my teaching for the last 5-6 years, is the concept of spontaneous organization. That when we provide alignment, when we provide the right load, and we provide the right tempo, the neuromuscular system organizes itself spontaneously, and through practice we become efficient. So this is a possibility of why the work we do with Pilates, gyrotonic, dance, Feldenkrais, martial arts, yoga, have so much benefit to us, far beyond what we understand, because we're focusing typically on alignment and dynamic alignment and the idea of varying the loads and the tempos, and that by doing that we strengthen our neuromuscular system to be able to respond to movements in a spontaneous format. It was Blandine that said that complex movements require spontaneous breath. When we look at that kind of organization where we're moving our body through space in a sporting activity or dance activity, or even just opening the door, picking a baby up out of the stroller, all of these things require spontaneous organization. So with that being said, we took those same 45 teachers and we asked them to perform the simple task of sit to stand. And what we found was that 39 of the 41 teachers had normal spontaneous contraction of the pelvic floor in the upward direction. And so we could safely say, with this group at least, that the breathing mechanical displacement and the spontaneous with sit to stand were just about the same. There's only 1 or 2 people different between them, but they were the same individuals. And what was interesting in this study is that by the time we got to the last person that we saw did not respond to the spontaneous load of sit to stand, we did an ultrasound. We had 2 of them there. We did an ultrasound of her diaphragm and her pelvis at the same time, and realized that she had contractures in her abdominal wall and that her diaphragm was actively insufficient. And what that means is that when she breathed with her accessory muscles. She did not breathe with her diaphragm. So there was no displacement of the diaphragm, which would make sense of why there would be no displacement of the pelvic floor. I have another question on the floor from Michelle Lee. And she asks, could elasticity of the pelvic floor or lack thereof be a factor in the misconception of what was happening to the pelvic floor? And it's a wonderful question, Michelle, because you're right on the money, I think, in what we're looking at here. When we think of the type of tissue now, we're talking a lot about fascia. We're looking at fascia's involvement in the pelvic floor. We're looking at fascia's involvement throughout the body. And the question is how do we maintain the intra-abdominal pressure with as little energy as possible? And this is why we think that a lot of these properties, when the body is aligned correctly and intact, then those tissues will work probably more in the elasticity realm than actually a contraction. I think the contractions come when the load continues to get heavier and heavier and heavier. And I see another question that comes up, which sort of leads into that. And Shani Haas, hi Shani, from Utah. Were any of the subjects asked if they had a diastasis rectus? We actually did check them for that. And, you know, funny enough, some of the women who had a number of children naturally had greater elasticity, probably or flaccidity, and had greater displacement of the pelvic floor than those who had not had that, had not either had a diastasis or not had it. So I think that there was just greater movement because of the lack of elasticity in the tissue. So when they did draw on the muscle, they actually had greater displacement. And that's something else that needs to be asked or questioned. And that leads me to the next question, sort of on the tail of you, Shani, which is, if we were to look now at women that have pelvic floor dysfunction, so incontinence, pelvic floor prolapse, other problems like that, it would be interesting now to evaluate and see what about their breathing mechanism and how about their elasticity of their tissue. If they have a huge diastasis, like a hernia of the abdominal wall, are they able to maintain that intra-abdominal pressure? And if not, does that pelvic floor become hyperactive or flaccid? Does the diaphragm become actively insufficient, or does it work harder and descend lower to try to compensate for the loss of integrity of the anterior abdominal wall? And these are questions that we're just getting ready to ask in the next level of looking with Pam and with Dr. Larry Cahalan, who's a respiratory therapist or physical therapist dealing with breath and with pulmonary function, is maybe what we're seeing with people that have pelvic floor dysfunction, they get better with Pilates, might be because of the facilitation of breath, and in particular diaphragmatic breathing, and not so much the contraction of the abdominal wall and the pelvic floor. And that's just a hypothesis right now, a theory that we're throwing out there, but it's something that we think might carry some weight as we do further investigation into these areas. So again, I think I'm at the end of what I want to present today. I would love to answer any questions or thoughts that you might have. I think a take-home message for the day is that maybe we need to be looking more in our teaching techniques to use spontaneous organization. And again, I think those three tools that help us with that are going to be alignment, they're going to be load, and they're going to be tempo. And those are three tools that I think are much more effective of teaching efficient core control and body organization than teaching volitional muscle contraction. And if we want to, while we're waiting for questions, we can try a little exercise just where you're sitting. If you sit nice and tall, and we're just going to do a little rotation activity in our chair. So bring your arms across your shoulders, and I want you to lift the pelvic floor up and draw the abdominal wall in and rotate your body. Just sort of feel what that feels like. All right, and then relax. Now this time, I want you to slack and just go into a really slouch posture. And I want you to imagine that each of your discs are like little balloons. And if I was to pump up those balloons in between all 23 segments, and you get that nice tall feeling, now bring your arms across your chest, and now do your rotation, and notice how much more movement you have in that rotation. And this is just to give you an idea that the right image, the right alignment, you notice that you didn't need to use nearly as much contraction as when I told you to hollow your abdominals or lift your pelvic floor. I do have a question on the floor here from Betty Charney. Thank you, Betty. Age range of the teachers that you tested. Our youngest was 22, and our oldest was in her late 60s, 67 or 68. And again, we did find some of the younger girls that were teaching and really had these hard bodies were actually in that group of 4 or 5 that did not have diaphragm displacement. One of them complained of incontinence, thinking it was funny when she bounced or jumped, and had these amazing looking abdominal wall for a young girl, but she had the negative response. Pelvic floor went down, diaphragm didn't work, and she was the one we said had an abdominal contracture. So she'd never had kids, never had any pelvic floor injuries, but she did have incontinence. Good question. Monique Romeko asked me if we'll conduct further studies on a group of men. Now, that's a great question. We took about 10 men. That was all that would do the study at the PMA conference out of the 200 that we have. And so far, 100% of Pilates teachers that are male were able to lift the pelvic floor up accurately with their proprioception. So we sort of dropped them because we didn't see any variance I have to put a shout out for Brett Howard, who had the most amazing pelvic floor lift. But the idea is that most of the men that we see with cueing their own lifting pelvic floor seem to lift in the right direction. But I would be glad to look at another way of interpreting, like maybe we look at spontaneous and maybe we look at the breathing factor with men, which we did not yet. And I have another question from Caroline again. Would you consider the sit-to-stand exercise did you notice the highest activation of pelvic floor? And the answer to that is yes, of what we observed. There was a study done by Daniela, and I always forget her boyfriend's name, who conducted the study, but he developed a intervaginal device that measured intra-abdominal pressure. And he had about 20 Pilates teachers insert the device and do a baseline standard scale. Shani would remember this because I think she was in that group doing the study. And the sit-to-stand showed to be more intra-abdominal pressure than almost all of the Pilates mat exercises that the teachers were involved in. So I would feel comfortable saying that a sit-to-stand is definitely a good measure, a good functional measure of that. If you wanted a Pilates exercise that was tremendous at organizing the pelvic floor, doing washerwoman or hamstring one on your knees is a fantastic way of alignment, load, and tempo to be able to recreate that pelvic floor coming up spontaneously. You don't have to say anything. If you keep their femurs vertical, that pelvic floor is going to fire. I have a question here from Nancy again. Teaching lower core activation, typically fingertips inside ASIS in supine, and notice a gentle plumping of the transverse abdominis contraction. So if we teach spontaneous transverse abdominis multifida, I'm not sure I understand that, more of a comment, but again, it's the same family. These are subconscious spinal cord reflex muscles that Nancy are responsible for maintaining intra-abdominal pressure adequate for the anticipated load. So Panjabi defined stability as being the appropriate amount of stiffness for the anticipated load. If we teach it, okay, I see the second part of it now, Nancy, sorry. If we teach it that way, then transverse and multifidi light up naturally as well. Yes, I think they do. I mean, we put the ultrasound on and we can teach somebody a volitional contraction of it. So, and I'm not saying that we shouldn't do volitional training. What I'm saying is that for function and the best efficiency, that we would look more for spontaneous cueing rather than going into, telling them to contract an area. Tactiles are fantastic as well. It's a little awkward at times to do tactile with pelvic floor. But I will use the sit bones occasionally as a tactile cue and tell them to draw that closer together. Let's see, I have another good question up here on the floor. This is from Hallie. Hi, Hallie. Good to hear from you. Let's see. Last November at the PMA, one of the subjects was performing the movement wrong. 35, had 3 natural births. I do have DR. And previous abdominal herniated diastasis. I would say breathing exercises, read this for everybody here. I'm just trying to get caught up here. There it is. I would say breathing exercise and inversion have completely brought new awareness to the pelvic floor for me. I think that's fantastic, Haley, because again, you're waking up that diaphragm, and I think when that diaphragm wakes up, it does something to the pelvic floor. We still need to investigate it, but I do believe that's the link. And you say, I think there was a disconnect in the nervous system after having 3 babies, and have we considered testing the pelvic floor contraction in an inverted position to see if the reverse of gravity has an effect of releasing the diaphragm and reteaching this movement? And I'll stop there in the question. It could very likely, Haley, be that just like we use the springs to assist people with movement, using gravity, we can use it to assist as well. So, for example, you might not be able to lift the pelvic floor up against gravity, but maybe if you're upside down and inverted, you could start getting the contraction or the organization of those fibers. So that would definitely be worth investigating. And you said, lastly, let's see here. It seems the spontaneous activation came back to me fully after training breath work in the inverted position. And I hope I'm not too far off base here, but this has been a primary focus of mine since testing. And I think you're right on target, Haley. I think you're right where you need to be, and that's creative to think of the inversion. The question I would have in the inversion again is this really about getting the diaphragm to work correctly, or facilitating the pelvic floor independently of the diaphragm, or them together? And those are some questions we're going to have to ask in future research, and would love more of your thoughts along those lines. Let's see, another question here. Let me just get caught up. All right, Jill Mickelson. Hi, Jill. Did you take any past medical history information for subjects, and any of the subjects have low back pain, which could have affected the pelvic floor response due to inhibition? We did have them fill out a personal history form that went along with each one of them, especially in the 79 group, and we did not see a correlation with any kind of incidence. Not that there wouldn't be, but the question I would have going back more than that is maybe some of the ones that have the spastic pelvic floor and we're actually pushing down might correlate with that low back pain. And that might be another good question to ask. Ben, you bringing that up, I would ask that question of myself. Is if I was in a lot of low back pain and I was over-recruiting, would that also over-recruiting carry over into my diaphragm, my pelvic floor, and hence when I was asked to lift my pelvic floor, I over-recruited and actually increased more intra-abdominal pressure and pushed the pelvic floor down. That might be a very legitimate strategy. Let's see. You guys are asking such good questions. Let's see, let me come back up here a little bit. Faster than I can read them. I hope you don't see my bad posture trying to read them on my computer screen. Let's see. Here we go. Julia, nice to hear from you. At which phase of the sit to stand exercise did you notice the highest activation of pelvic floor? It was the initiation. Matter of fact, Julia, we even saw it when they thought that they were going to shift the weight onto the feet. So great question. Nancy, definitely think breathing is the most compelling aspect of this subject. Love the direction you're taking. Thank you, Nancy. And again, I think we need to ask more questions, but I do think we're going to find that breathing is a much larger component to pelvic floor health than we've given it credit for in the past. Rebecca Stevenson, FYI, the sit to stand is the hardest for males post-prostatectomy. That would make sense, right? As there is such a strong moment of downward pressure creating a leak point. And this is one of the areas where, for women as well, that we experience the most incontinence is that sit to stand. So thank you for bringing that forward. I wasn't aware of that with men following prostate surgery. Let me get to the right place here. Let's see. Let's see, Nancy. I got you, Nancy. Vicki Elliott Brown. Did you look at pelvic position, and was there a difference in pelvic floor between a neutral and a tilted pelvis? I think that is, we put them into a neutral position, Vicki, but I do think that that was interesting, as a lot of them, when they thought they were lifting the pelvic floor, actually strategized and went into a posterior tilt. And that would be an example of using more of the glutes and adductors and hamstrings to be able to facilitate what they interpreted as a pelvic floor lift, where typically you could stay in a more neutral position and just contract the pelvic floor independently. Hope that answered your question. Question from Vicki, how do you cue pelvic floor lift? I almost stopped altogether now of using verbal cues for pelvic floor. I tend to just use position and certain exercises or sit to stand and be able to see their ability to organize. But the times that I do need to facilitate that, it's a little graphic, but I often will use the image of a tampon. And if the tampon was being drawn out and you didn't want it to be drawn out, how would you prevent that? Now, I've never worn a tampon before, so I don't know what that feels like. But I have had the best results from that with ultrasound, and that was a little trick I learned from Hadar Schwartz. I can hear you guys laughing. You think I can't hear you laughing? I can hear you laughing. Paulina from Russia. How are you, Paulina? Is it possible to restore the function of the pelvic floor fully after multiple natural deliveries? I think that's a loaded question in the sense that I would say probably not. But to get function, I think that we can get function. I mean, there obviously can be such severe pelvic floor damage at times with birth. Women experience that they need to have surgery, they need to have mesh, they need to have different types of procedures for prolapse, just depending on the severity of the damage that was done. And so, I mean, I think we do the best we can do. And as I mentioned, I think we lose elasticity. I shouldn't say we. I've never had a child myself, but women having children naturally do lose some elasticity of the pelvic floor with each childbirth. And I think that also varies. You can sort of look at the difference between woman to woman of how many of them get stretch marks and how many don't. And how does their collagen and their elastin in their skin and in their tissues react. So there's a lot of factors at play as to how much damage is done, but it's a great question. And again, you know, we see people with severe disabilities and impairments, and they might not, you know, if they've had a leg amputated, they're not going to get their leg back, but we can use a prosthesis and teach them to perform at very high levels. And likewise, I think the pelvic floor, any part of the body that gets impaired like that, that we can always help and make their life better. Michelle Lee, is there any exercise that could release the pelvic floor? Again, I think that the best thing is breath. And what I'll use sometimes is a deep squat, Michelle. So at the end of the reformer class, I'll have them hold on to the foot bar off the edge and go down into a full squat and just stay there and their elbows between their knees pushing out, and to take a deep breath and really feel a Buddha belly, like feel that drop down. I started doing that first with a pregnancy class that I was teaching, but I do that with everybody now, men and women, just getting there, because I feel like the sitting posture and the tension and the amount of back pain that we see, that we have way too much pelvic floor tension, and I would dare to say that we probably have more incontinence due to that than we do to flaccidity. All right. All right. Let's see. I think I just saw a really good question coming up here. Hold on. This one we did. All right, Tom. It is so much fun to have the object evidence to help us sort out the intuition about what is and is not working for our clients. Thank you. Thank you, Tom, for that comment. I appreciate it. Mary Janine, what exactly is spontaneous cueing? I thought you would never ask. Mary Janine, spontaneous cueing is really from an organization standpoint. So when we put you in the right position and the right load, and we ask you to do a function, the body, because of the load and because of the alignment and what you're perceiving the activity, naturally responds. Now, I want you to think about the first time you learned to ride a bike. You probably over-recruited and you did way too much. So your jaw was tight and your arms were tight, and very quickly you learned to find your balance on the bike, hopefully, and then the next thing you know, you're riding a bike very relaxed and even at times without your hands. So we know that in the learning phase, motor learning, that our body will respond to the task that it's given. And I much rather be teaching task-based movement than isolated contraction movement. And I hope that helps. And I think that we as a movement professional organization would start moving away from trying to teach isolated muscle contraction and think that that's going to correlate necessarily to functional movement. And so I much rather take the spontaneous cueing approach of, you know, things where bones in space creates a beautiful spontaneous organization. Tempo and fluidity and continuity of movement all create beautiful spontaneous organization. If you tell somebody to recruit a muscle while they're doing something or to breathe all the time, you might be over-recruiting. Again, I don't know that that's a problem. I just think it does not facilitate efficiency of movement. And one of our primary objectives in Pilates is to facilitate efficiency in movement. Great question. a follow-up to someone else's question from Sarah Carey. Says, do you have an exercise to release pelvic floor muscles when someone has a hip injury and cannot do it in a full squat? You know what I tend to do is I use a manual technique, and I know that's not fair, but I'll lay somebody on their side and come in over the pubic rami, drop in on that side where they're having the hip problem, and I'll release it that way. That being said, I think that you could do the squat on the reformer or with the feet in straps where you would not have the load of a full squat with gravity, but with them either on a wedge or on their back on the trapeze table and long springs could potentially get them in that inclined position and breathing into their pelvic floor without incurring any more additional torque to their hips. Vicky, do I recommend Kegels? I'm going to get in trouble for saying this, but no, I don't recommend Kegels because all the research shows that whatever we're teaching people to do volitional contraction is not what we're seeing. And you can imagine if 45% of experienced movers and teachers are doing it wrong, what are our clients doing? Which would be a great study, and I would encourage somebody to do it just to go in the general public. And let's measure and see and find 1 or 2 cues and see who responds the best to it of a Kegel, or just people coming out of the gynecologist's office and asking them, do you mind if we test your Kegels with an ultrasound? And I bet we'd find that majority of them are doing it wrong. So I would tend to think that we're going to be better off teaching them spontaneous organization with breath and with movement and bony alignment. Renee Lizotte. Since sit to stand is showing to be more effective in activating the pelvic floor, would you recommend teachers a large segment of Pilates classes in vertical position rather than supine? And the answer to that, Renee, is a definite yes. I'll give you another little hint here that we've seen, and I typically say the 3 areas of the body that we need to pay attention to is the thoracic mobility, hip extension, and ankle dorsiflexion. The majority of our injuries actually happen because of the lack of mobility in these areas, and I think that's why we see that so often. So hopefully that answers your question, and yes, incorporate more standing work. I love squatting work. I love to do things off the end of the reformer as well to be able to facilitate that load. Mary Janine, again, what exactly? I answered that one already. Question from Carolyn Thomas again, when is it decided the pelvic floor is rigid? Is using the ball, sitting on a ball a good approach? I know a lot of therapists that teach that. I don't have any problem with that, like doing a Yamuna ball or maybe a little bit softer just to release the pelvic floor. Absolutely. Tactile feedback is a great way to get tissues to release, especially if they're spastic. There's also, you know, they can see therapists that do internal work that are able to release that. And there's also some other biofeedback tools that are used to get people to release that. Great question, Carol. Teresa Maldonado, without... There we go. Let's see. Without having ultrasound with clients, is there a way to determine whether they are flaccid or hyperactive in their pelvic floor? And particularly interested in women post-natural births. I don't think you can have a really accurate unless you're actually palpating pelvic floor or you're using an ultrasound. But I think when you look at certain behaviors and certain movements, you can be pretty sure that they're using their pelvic floor if they do the movement correctly. And that's what I was saying. A good little test is wash your woman on your knees on the chair, and to keep the femurs vertical just an inch or 2 away from the base of the chair, and have them see if they can roll their spine up on top of the pelvis. And if their pelvic floor is not working, they won't be able to do that exercise. And that would include not working because it's spastic or not working because it's flaccid. Paulina, should we use any images for pelvic floor and transverse abdominis contraction? Align the bones, Paulina. Just think of like what I did with the balloon between the vertebra, or think of the fanning or opening of the sit bones when you go down into a squat. Think of the diaphragm descending and pushing the viscera and stretching and opening the pelvic floor. Think of it rising up on the exhalation. And I would get away from the volitional contractions of it. And again, you can be creative. There's lots of good ways to get that. But again, bony position and direction is my favorite. Misty Wooden, how are you, Misty? Would it be relevant in future studies to ask about stress levels, knowing the relationship to breath and stress and breath in the pelvic floor? Again, Misty, this brings up a really good point, and that is that if we see this relationship between diaphragm and pelvic floor, which we know exists in the hydraulic amplifier, but maybe we never expected it exists as much as what we think. So somebody that's stressed, not breathing correctly, would obviously, in this kind of a theory, have pelvic floor deficiencies. And so controlling stress, restoring breath, or restoring breath to control stress, pelvic floor function should return. And let's make that our question, should we? And just see if we can't continue to ask that question in itself to see what's going on. Let's see. Question from Barbara Blasco. Do you find that individuals with diastasis use a strategy to anterior breathing patterns and over-recruit and can't make posterior breath connections due to a lack of ability to get the pelvic floor contraction or insufficient diaphragm breathing? Anytime you have a breach of the anterior wall or any part of the piston, I call it, that hydraulic amplifier, you will see the compensation, and that would be a natural compensation to a loss of anterior wall stability. Remember we talked about that a little bit earlier today, that with I think it was Shani's question, Shani Haas from Salt Lake, when you lose the anterior wall and the ability to close it. Now, a lot of times women have diastases, and the fibers actually of the transverse still cross underneath the linealbus, so when they contract, they create intra-abdominal pressure and can close a little bit, even though you see the diastases or a little bit of the viscera pooching through the diastasis. When those fibers contract and there is no closing, that's one of the few times that I really do encourage them to get a consultation with a plastic surgeon to be able to close that anterior wall, just for that very reason, Barbara, that you're asking, is that they will tend to have increased low back pain because they'll end up belly breathing and trying to hold everything together through the back or posterior pillars of the trunk wall. And I think it's a great question, great ask. One thing you might try doing with them is taking some elastic tape or some kinesio tape and tape the diastasis shut and see what happens to the amount of tension or pressure in their back. Just a hint. Trish Mayer, have you seen any information in regards to spontaneous organization in the forward or rear lunge position? And absolutely, as long as that pelvis stays vertical, when you're descending, it's the same. It's going to be the same organization we would see in a sit to stand. So that pelvic floor, that intra-abdominal pressure has to be high to allow us to descend and ascend against gravity. So absolutely with lunges. Maricel Hammers, with pelvic organ prolapse, which best pelvic exercise is best recommended? Again, depending which organ is prolapse, so it could be a vaginal prolapse, it could be a rectal prolapse or a bladder prolapse, and it depends on the severity of it. So those that are not necessarily needing surgery, I think it ties in with everything we're talking about. We do the best we can. They should be seeing a specialist that deals with women's health and is actually teaching that, where we as Pilates teachers would be teaching general whole body organization and alignment and movement, with the idea that if there is the ability to create a spontaneous organization, that it'd be through that type of activity, rather than the isolation that the physical therapist will probably be doing to try to wake up some of the tissues that have really been damaged, or post-surgery. So if they had surgery, we have to also be careful of that. All right, let's see where we're at here. Let's see, Emily Bench. Nice to hear from you, Emily. Let's see, what about men with prostate issue surgery? I've been asked by several men if after prostate surgery, practicing Pilates and strengthening pelvic floor muscles could help them with their aftercare and their sexual dysfunction. You know, that is such an important topic right now, with so many men suffering from prostate issues and prostate surgery. I would put it in the same category as the prolapse, depending on the surgery. I do know of a couple surgeons that are just telling their men to do 1,000 Kegels a day, And I think that's probably the wrong approach. Matter of fact, I feel strongly that's the wrong approach. But I do believe that just gently moving them through space and increasing and changing the orientation of the pelvic floor, so going from supine to quadruped to seated to kneeling to half kneeling to standing, working the body in abduction, adduction, and working it in flexion, extension, that the very direction and very loads are going to be the very tools that we use to create the spontaneous organization. What I would be careful of is doing things too early that are too much load for the pelvic floor, because it's not going to be active. It's not going to be working the way it should. They will have some incontinence. They will have some sexual dysfunction. And a lot of times it's just giving them hope that things will get better, and they do get better over time, and that after a couple months that then they're a little more ready to be able to do some of the more aggressive activities that we would do in Pilates. Great question. Marcel Hammers with a question, which pelvic, let's see, yeah, I answered that one already, sorry. And I answered Misty Wooten's question. I think that takes care of all of our questions, and I think we're out of time. Perfect timing, everybody. It was a real pleasure.